My presentation today is Pathophysiology of Diabetes, and I have been the student of Professor Mahmood Malik in my final year. I have been his senior registrar and I have been his assistant professor. I have learned a lot of things from you, sir. Thank you very much, sir. I learned many things about diabetes from Professor Mahmood Malik as well. So today's presentation is Pathophysiology of Diabetes, and I will be going through this very briefly because this is the most predominant type of diabetes in Pakistan, and I will spend more time on it. Gestational diabetes is actually gestation-related insulin resistance plus pre-diabetes. It's a combination. Patients are predisposed to diabetes, and on the top they have gestation-induced insulin resistance, so they develop diabetes mellitus. And then we have secondary diabetes, which could be due to many endocrine disorders like Cushing's and others. Increasing information and research on diabetes too is carried out. Pathophysiology of diabetes in 1980s was, they thought that it is the impaired uptake of glucose at the periphery, at the level of muscle and adipose tissue, and it is consequently compensatory hyperinsulinemia which leads to excessive glucose production. This is what we knew. But in 1990s, they found out that blocking glucose entry into the muscle and into the fat cell alone was not sufficient to cause diabetes, because if we block this, compensatory hyperinsulinemia takes care of this. So there was other factors as well. Now we know the pathophysiology of diabetes. We know it is the insulin resistance, decreased glucose uptake at the periphery, along with more hepatic glucose production. Hepatic glucose production is increased, and there is dysfunctional insulin secretion, there is decreased insulin secretion, and there is increased lipolysis. Plus, there are new factors which have been added. One is the incretin effect, other is increased glucose reabsorption from the kidneys, and then is the islet cell abnormality in the glucagon secreting cells, A cells of islet, and then neurotransmitter dysfunction at the brain level. I will be discussing these one by one. So this is what we know about the pathophysiology of diabetes. That is, I just mentioned all of these, decreased peripheral uptake of glucose and all that. Let's come to insulin resistance. Insulin resistance is different in fasting and well-fed state. In fasting, during fasting state, body still needs a continuous supply of glucose, because our body depends on glucose, especially brain tissue needs glucose. It exclusively needs glucose for its metabolism, and liver provides this glucose. In non-diabetic patients, this is around 2 mg per kg per minute, but in diabetics, this hepatic glucose production is more. This is 2.5 mg per kg, and this adds up to 20 grams of glucose to the blood sugar level. And this we have found that in the presence of hyperinsulinemia, actually insulin suppresses the hepatic glucose production. Whenever there is insulin secretion, because somebody takes glucose, somebody takes food, there is a secretion of insulin, and that insulin suppresses the hepatic glucose production. But in diabetics, even in the presence of hyperinsulinemia, there is more glucose production. This signifies that insulin is not acting, there is insulin resistance at the liver level. And glucagon, which is another hormone, also contributes to this, and glucose 6-phosphate, induction of this hormone also contributes. While we are well fed, then insulin resistance is different. Then it is at the level of muscle and adipose tissue. These are the two other sites where we have insulin resistance. In well-fed state, the muscle, which is responsible for disposal of glucose postprandially, after patient has taken food, this glucose is not disposed of into the muscle and into the adipose tissue. But here, because of the resistance of the action of insulin, there is improper glucose disposal. And this resistance is not only at receptor level, it is also at post receptor level, and this leads to decreased phosphorylation of glucose. Actually, when glucose enters into the muscle cell, it must be phosphorylated immediately, otherwise it will escape from the muscle again. So after phosphorylation, it stays in, and the enzyme for this is glucose 6-phosphatase. And there is decreased phosphorylation. That means now this glucose will not stay in the muscle. Whatever glucose has entered will not stay in the muscle, will again escape from the muscle. And once we have glucose into the muscle, body stores that glucose into the glycogen, and this glycogen is also reduced. So insulin, these all mechanisms signify insulin resistance. The second pathophysiological mechanism in diabetes is beta cell dysfunction. Beta cell dysfunction, we know beta cell mass keeps declining with the advancing age. So age-related decline in beta cell is well known even in people who are not diabetic. But insulin resistance at periphery also contributes to beta cell dysfunction. How? Number one, it causes insulin resistance at periphery causes hyperinsulinemia. And once pancreas secretes insulin, there is a similar number of amyloid polypeptides. They are also secreted with insulin, and these amyloid molecules are toxic to the beta cells. They are deposited in the beta cells, and they reduce the production of insulin by decreasing the beta cell number. Another is lipotoxicity. People with diabetes have elevated serum free fatty acids. They have elevated serum free fatty acids, and these free fatty acids are responsible for insulin resistance as well, and they also suppress the insulin secretion. So not only they produce insulin resistance, whatever insulin is released, they also lead to insulin reduction in the insulin action as well as reduction in the insulin production, both. And long-standing deposition of fat also decreases the beta cell's response to glucose. Then glucotoxicity. Glucotoxicity is whenever blood glucose increases, again pancreas suppresses the secretion of insulin. And both the first phase and the second phase, insulin secretion is depressed. And it was seen that as much as 16 milligram per gram, 16 milligram per deciliter, it is not GL, it is DL. 16 milligram per deciliter elevation, only mean elevation of this much glucose suppresses insulin production markedly, and once you decrease this blood glucose level, pancreas comes out of this glucotoxicity. The third pathophysiological mechanism is the adipocytes. They have their metabolism which is deranged. So deranged metabolism of adipocytes. How? Again, there is insulin resistance. Fat cells are resistant to the anti-lipolytic action of insulin. Normally, insulin is anti-lipolytic. It does not allow lipids to be dissolved, and they should not be flowing into the circulation. It keeps the fat where it should be. But if there is resistance to the action of insulin, the result is there is more lipolysis, and this leads to continuous increase in free fatty acids, and this elevation in free fatty acid leads to these fatty acids, they lead to gluconeogenesis. So they are converted to glucose formation, further contributing to the glucose, and they also leads to impaired insulin secretion, just discussed in the last slide, and they also induce hepatic and muscle insulin resistance. And on the top, these dysfunctional fat cells, they do not produce adiponectin. Muscle cells produce many hormones, and some are harmful. The production of those harmful hormones which lead to inflammation and atherosclerosis is increased, while the production of adiponectin decreases. Adiponectin is an adipocytokine. It is secreted by adipocytes, and it increases insulin sensitivity. But so insulin acts on fat cells. Fat cells produce adiponectin, which increases insulin sensitivity. If there is insulin resistance, there is no adiponectin further contributing to insulin resistance. And these fat cells are also dysfunctional. They are enlarged and they are not capable of storing fat. They do not store fat because this is their main function, but they do not store fat. Fat stays in circulation, leading to atherosclerosis and all that. The fourth is decreased incretin effect. Incretin are the hormones, they are secreted by the intestine. If we have the same level of blood glucose from intravenous route and same level of blood glucose with oral route, the oral route produces more insulin. The result being, in oral route, not only glucose stimulates the beta cells of pancreas, but the two hormones, GLP-1 and GIP, they also stimulate the beta cells of pancreas, leading to production of more insulin. In diabetics, this incretin effect is also reduced. So GLP-1, which is a potent inhibitor of glucagon secretion, which is anti-insulin hormone. So normally what happens is, patient takes food, there is insulin production as well as there is GLP-1 production, and this GLP-1 production suppresses the glucagon and increases the insulin production. But in diabetics, not only that insulin is not produced in response to GLP-1, there is also rise in glucagon secretion, and that leads to rise in plasma glucose level and more hepatic glucose production, because glucagon also stimulates liver to produce more glucose. Then alpha cells, it has been recognized that the alpha cells of pancreas are also faulty. Insulin has a paracrine effect, it suppresses the glucagon normally. It acts on the A cells and suppresses the glucagon secretion. In diabetics, this glucagon secretion is not suppressed. Rather, this glucagon secretion is increased, and this glucagon promotes hepatic glucose production. And recently, they have found that in diabetes, beta cells do not die, rather they de-differentiate into alpha cells. So beta cells also convert into alpha cells, producing more glucagon. And another recently identified mechanism is increased renal glucose reabsorption. Normally, our kidneys filter around 162 grams of glucose daily, and this is reabsorbed through sodium glucose transport 2 and sodium glucose transport 1 receptors. They are receptors in the renal tubules, and they transport this glucose back to the circulation. But in diabetics, they have more induction of messenger RNA. This leads to more SGR receptors, and the result is people who have more these SGR receptors, they reabsorb glucose more than normal people. Normal mechanism should have been that in the face of hyperglycemia, kidneys should be excreting the glucose, but instead of secretion, their reabsorption increases. So that is another fault, further contributing to hyperglycemia. And then there is dysregulated neurotransmitter function. We know the diabetes epidemic goes hand in hand with the epidemic of obesity. Insulin is a powerful appetite suppressor. You take food, there is production of insulin, it suppresses your appetite further. But in diabetics, they have found, in obese and diabetic patients, they have found that insulin is not acting on the brain properly. There is resistance to the action of insulin in brain as well, so appetite is not suppressed. That leads to more food intake. So you see, this further contributes to hyperglycemia. Now, how insulin acts? This is what I learned a few months ago in the European Association for Study of Diabetes, and they have come up with a gene, FOXO. What is FOXO? FOXO gene are the group of genes, it is derived from fork-head box, or ordinary fork-head box, because their shape resembles like the fork-head. So this is the gene which produces a FOXO protein. This FOXO protein is located in the nucleus, and this is a transcription protein. it leads to induction of production of more proteins into the cell. So this FOXO in unphosphorylated state, it is located in the nucleus. What insulin does is, insulin phosphorylates it, moves it into the cytoplasm, and once this goes to cytoplasm, this becomes ineffective. This is the mechanism of action of FOXO protein. You have high glucose, this leads to insulin production, it acts on second messengers, and this FOXO protein, which is normally attached to glucose 6-phosphatase. Glucose 6-phosphatase is the enzyme which keeps the glucose into the muscle cells. I just discussed. Okay, once glucose enters into the muscle cell and liver, there is glucose 6-phosphatase which phosphorylates glucose, which phosphorylates glucose and converts this to glycogen synthesis. So glucose stays into the tissues, not into the circulation. That is stored. And this FOXO gene is a promoter region for G6-phosphatase, and it induces the G6-phosphatase. That means if FOXO gene is stimulated, FOXO protein is acting, if FOXO protein is acting, this leads to more production of glucose 6-phosphatase, and more glucose is internalized, more glucose is stored, less glucose goes to circulation. And insulin may move this out of this. So FOXO promotes production of glucose by liver by promoting glucose 6-phosphatase. Insulin inhibits this phosphoprotein action, and removing FOXO protein leads to diabetes. This is how it goes. So if there is no FOXO, glucose 6-phosphatase, and this converts to glucose production. So this FOXO protein also controls glucokinase. Glucokinase again synthesizes glycogen. I'm sorry, मैंने पीछे इसको यहाँ पे ये जो glucose 6-phosphatase है, this stimulates converts the glucose for production output. And once insulin inhibits this, no glucose goes out. And the other enzyme is glucokinase. This is what promotes glycogen synthesis and lipid synthesis. FOXO also promotes glucokinase. FOXO protein promotes glucokinase, and this leads to more production of glycogen and more lipid synthesis and less production of hepatic glucose. But if insulin acts on it, this FOXO is inhibited, and this leads to rise in glucose production in cases of diabetes because of the resistance to the action of insulin. So FOXO allows liver to decide whether it is going to turn the glucose into the circulation or whether it is converting it into the fat. They are implicating FOXO proteins in other target tissues of this insulin, but mechanism is still not understood. Like in FOXO in adipocytes, it negatively regulates adipogenesis. So it suppresses the production of fat cells, it halts their growth into the growth cycle, so less fat cells are produced. And if there are less fat cells, they do not store fat. So less storage of fat. So in summary, the pathophysiology of diabetes is there is decreased peripheral uptake of glucose, plus there is increased hepatic glucose production, and there is decreased insulin production, there is increased lipolysis and decreased incretin effect, increased glucagon production, increased renal reabsorption of glucose, and neurotransmitter dysfunction, and insulin acts through FOXO proteins. This is still what we have known. Thank you very much.